Select Medical is one of the occupational therapy groups that is working at our rehab through our rehab department here at Emory. Ms. Jaya is going to explain the use of an occupational therapist and the sorts of services and things that you can do to help communicate and live with somebody with dementia. I need to tell you that in order to get to an occupational therapist, your medical provider needs to make a referral for you to get to the occupational therapist. At this time, I'd like to introduce you to Ms. Tina Jaya, who is our guest occupational therapist, to help discuss things we might do to help work and live with somebody who has dementia. Ms. Jaya.
Thank you very much. It's a pleasure for me to share my passion, which is occupational therapy, and how we can contribute to people living better with dementia and Alzheimer's disease. So I'm an occupational therapist, and I also specialize in hand rehabilitation, and also have a passion for public health and educating people, because one of the things that's the key to what we do as occupational therapists is I am trying to find my forward button here. Yeah, is improve people's quality of life. So as occupational therapists, our focus is managing daily living skills for everybody, no matter what's going on. And in particular, for what we're going to be talking about is we focus on managing daily living skills at any stage of Alzheimer's disease. Alzheimer's Association and most medical journals and information classify Alzheimer's disease into 3 stages: the early stage, the middle stage, and the later stage. And with these stages, there's different levels of changes that I listed, the things that are most common and that impact our function the most. So people have physical changes, cognitive changes, and behavioral changes that either they as individuals notice or their family notices. The key ones that happen with physical changes are mobility, change in mobility, in vision, sleep patterns, and how your bowels and bladder move. And there are medications, but our focus as occupational therapists is to help you function as best as possible and be as independent in all aspects for as long as possible. We also address the cognitive changes, and the top ones are the changes that happen with memory, attention, language, and orientation. The other area that's pretty significant is these changes that happen in behavior, in personality, mood, emotions, and interests. Please remember that we are not experts in changing behavior. We focus on strategies that help you function as best as possible despite these changes. And our emphasis and our focus is I'm not finding my assessing to see what stage somebody is or what deficits are there, and coming up with strategies to increase their independence. And when we are looking at this, the main things are identifying what aspects can we still impact for the individual, and what adaptations we need to do in the environment, and what other things can we do to train the client and the caregiver to live safely despite what's going on. We also look in clinic and in home environments to identify strategies to increase independence. And when we are in the home setting, or even when you come into clinic, one of the ways we focus on safety and addressing all the changes that happen physically is to discuss room by room what are the safety strategies based on the stage. So for example, when if it's a female or a male who's beginning to show signs of Alzheimer's, and they have a little bit of memory deficits, do they remember the things they need for the refrigerator when they go grocery shopping? If they don't, discussing things like having a grocery list, or if it's somebody who likes to use the phone. Most of us now are attached to our phones, or we are attached to some form of device. Using those devices, they have a lot of resources that we can use to teach people to improve their memory and be more independent in the kitchen. Because one little problem like not remembering what you bought can be very frustrating if it's an essential ingredient in meal preparation. And then things in terms of the bedroom, you are looking at being able to get in and out of bed safely. If you are needing to go to the bathroom more frequently, being strong enough to get up, go with the altered lighting, and doing this safely. And then that applies the same to the bathroom. So we look at each individual person, where they are, what are the things that are challenging, and how can we help increase independence, and practice and apply repetition, family and caregiver training, in addition to training the patient to maximize. And oftentimes we do have to depend on tweaking the environment to increase safety. And for people living with Alzheimer's, the key daily living skills that are affected are self-care, which includes feeding, bathing, dressing, and managing in the bathroom. Managing medication, knowing when to take your medications and what medications to take when. Managing your finances, driving, and meal management. So depending on what deficits are identified at the time of the interaction, we then put together a program that focuses on what needs to be addressed. Sometimes it's something as something like managing the medication. We stop and look, is it enough to put in a scheduler? Do you need a reminder on your phone so that you know you have a scheduler, but because you forget, if you have an alarm on your phone that tells you it's time to take this medication, then you take it. Facilitating that training for the person and the caregiver so everybody has a routine and is on the same page. So the strategies, I broke down these strategies so we could kind of discuss them a little bit. So the strategies for addressing physical changes start with just moving. So just your basic movement and routine activities, because at every stage of Alzheimer's disease, whether it's the beginning, the middle, or the late stage, something that's often observed is change in mobility. So when you can find ways to maintain routine movement and routine activity, you keep your body moving, your body strong, and a strong moving body results in a lower risk of falls. Falls are the biggest source of decline when people have Alzheimer's disease, because when you fall and change your routine, it is sometimes challenging to remember the routine once you are feeling better. Because once there is pain, the person who's not remembering and is not moving as well as before gets weaker. And then as time goes on, they move less because it hurts. And as they move less, they get more weaker. So it becomes a vicious cycle. So whatever activities can be done, and as the doctor was saying, especially pre-diagnosis, the more optimum your wellness strategies are as you are going over 50, the better, because the more physically active you are, it means your balance stays at optimal, your strength stays at optimum. When you fall, you recover better. But when you're weak, you fall really hard and your recovery takes longer. So strategies for working with mobility is increasing the routine activities, having a routine physical exercise program. It does not need to be complex. And sometimes when someone is in the later stages, even just stretching their legs with help really makes a difference in their mobility. Balance activities can be as simple as standing and doing dishes at the sink in increments. And part of fall prevention strategies and programs that are part of occupational therapy is coming in or interacting with the patient and getting a sense of what does their environment look like, looking at the lighting, looking at how many steps to get in and out of the home. What are the barriers to moving from one room to the other? Are there spaces or places where someone can sit and rest? Because oftentimes the highest risk for falls is someone gets tired while walking between the kitchen and the living room, or while walking between the kitchen and the bathroom. So establishing areas to pause and rest and sit and rest oftentimes increases safety and reduces falls. Vision changes come sometimes with just the physiological aging process, but they're also common when someone has Alzheimer's. And with some of the changes, it's not just not being able to see, it's also how you interpret what you see in the environment. So one example I'll give is those people who have floors, those tiles that have contrast, one patch is dark and one patch is lighter. In the middle and the later stages of Alzheimer's, the way people see those floors, they sometimes perceive the dark spots as holes. So as they navigate the floor, they get distracted and it increases the risk for falls. So,
Jaya,
yeah.
can I, on that point, when you say the pattern, would you tell us then that if we have black and white spots on our floor and we're living with somebody with dementia, to cover that up and make it all white floor?
No, so we would look and see, the first thing is just to educate so that people are aware. Because sometimes when you're aware, then you're not startled when your family member moves a certain way. Then you can kind of guide them and reassuring that it's okay. Because while it would be good to make such big changes, putting a rug is also something we tell people not to do because it increases the risk of tripping. So just being aware that people can recognize those spaces differently. I think when we educate people and they're aware, they can interact with their family members differently. And if somebody does have the resources to change the surface area, my recommendation would be to do something solid versus putting an area rug. Or if you have to put something, put it in a way that it's not a trip, something that increases the risk of tripping. Does that help?
Yes, that I just wanted you to be a little bit more specific because I'm a clinician and I learned that if you have a black hole on the floor, a black spot, they'll think it's a hole and they won't walk over it, won't walk through it. They will move at all. So that's what I just wanted you to clarify so that people understand a little bit.
Yeah. So it's so interesting that until I actually was in the environment, when I learned about this in school, it didn't really make sense. But when I was working in an environment that had an Alzheimer's unit, and we had an activity area that happened to have that contrast, you would see people avoid those areas or walk differently. So it increased that risk of falling. Mm-hmm. And that awareness and coming up with strategies helps reduce confusion. Because whatever we can do in the environment to help the person whose vision or their interpretation of the environment, their visual interpretation of the environment is changing. Whatever we can do to minimize that confusion, it reduces the behaviors we see with frustration and anger. Because oftentimes in the early stages, some of the behaviors that are elicited, it's really someone who is recognizing that their life is changing. They're recognizing that I'm not seeing the world the way it typically should be, and I am not able to control this. So one of the big things that we do is really educating and introducing strategies people can use. So going to that, sleep awareness, knowing that the sleep patterns are changing, the environmental modifications that can be done is having one, a routine that's consistent, two, having a sleep environment, making sure the lights go out at the same time, yet there's enough night light to make it to the bathroom, because safety is still an issue. So creating that environment that promotes sleep, trying to sleep at the same time, but being aware that sometimes it's not easy to keep that pattern. And then the bowel and bladder is establishing a bowel bladder routine. For example, encouraging that person to go to the bathroom after every meal often really helps. Let's move to the next slide. So the other area I'd mentioned is the characteristics that change as far as cognitive and behavior. And some of this I've mentioned as I've discussed, because function and rehabilitation as occupational therapists, everything ties in. We are trying to make sure somebody can function every single day. So with memory, using memory cues, those who like diaries or something that's pen and paper, using that. And as somebody's recovery change, as the condition progresses, knowing when to do less cues, use paper less, and then when it's appropriate to give verbal cues. And then using the technologies I mentioned, phones and smartwatches. Attention can be supported and modified by keeping a routine. Again, when someone is still in the position where they can use some form of schedule or calendar, having that and having that routine, have cues that helps them stay on schedule. And then using familiar activities to draw attention, like music, and having things like this on schedule. Behavioral changes, the anger and combative behavior that sometimes comes when you are able to identify a way to create an environment that's calm and anticipate triggers as the patient's condition changes. This also helps. And celebrating the small successes that happen every day. This is an area that we really focus on in therapy as we interact with caregivers, because working with someone with Alzheimer's is working with the whole family, because the success is not just working with that one person, but working with the people who support them, because their behavior and their ability first thing in the morning can be completely different to their behavior at the end of the day. So our focus also includes caregiver training, understanding the changes and anticipating the changes that will come. And sometimes they don't, but helping people know what resources are out there and what to expect and how to manage to balance their self-care while promoting independence in their family member. Please move to the next slide. So as mentioned, I'm part of the Select Rehabilitation Program, and it is part of an Emory joint venture. So we are a group of therapy clinics that are all over Metro Atlanta. A number of us who are occupational therapists are also passionate about cognitive rehabilitation. So whenever there's a need, feel free to contact me, and I'll be able to direct you to the closest occupational therapist who loves to provide cognitive rehabilitation.
Thank you so much, Ms. Jaya. That's very helpful. And I really want to direct people again to Ms. Jaya. She has her email address right there, HATINAWEDU, Jaya, at emoryhealthcare.org. Telephone number 770-461-6488. And just for the benefit of our audience, Ms. Jaya, how is occupational therapy evaluation paid for?
So most people who have private insurance or Medicare, this is a covered benefit. And the best way for you to receive the therapy and it be reimbursed is to make sure you get a referral from your physician. And once you get that referral, it can be from your primary care physician. If you have a gerontologist or neurologist, any of these physicians, once you have that order, we will evaluate you and establish a plan of care. So as we evaluate, we determine at what level are you, what do we need to focus on, and create a plan. And Medicare covers those services. And pretty much most insurances, but having the referral makes a difference.
Okay, on that note, are occupational therapists available for, you say Medicare and private insurance pays for it if you have a doctor referral. What about driving evaluations? Is that not an occupational therapy assessment?
Yes.
There are a lot of people who ask about driving assessments, and I'm of the opinion that if you don't feel comfortable with somebody driving, you disable the car. But a lot of people respond favorably to a driving assessment. Can you talk about how we can get a driving assessment?
Yes. So a driving assessment is part of the services offered by occupational therapists. Unfortunately, however, in the past 5 or so years, I think as long as I've been in Metro Atlanta, there has been a change where this is no longer typically reimbursed by insurance. So it is a service in Metro Atlanta. There are 3 places I know that provide driving evaluations. One of them is the Emory Rehabilitation Hospital on Clifton Road. They provide driving evaluations. The other is Shepherd Center. And then there is somebody who does his private practice out in Marietta. These 3 driving evaluation programs are the only programs that will take you on the road to do the evaluation. However, it is an out-of-pocket expense.
What does it cost?
$600.
So a driving evaluation is primarily an out-of-pocket expense. Main places to obtain it are the Emory Rehabilitation Center for Rehab Medicine on Clifton Road, Shepherd Spinal Center, and then there's another private practice entity that will do that.
Yes, but when I worked in Savannah, my experience was there were a group of neurologists and gerontologists there who would send their clients for evaluation by the occupational therapist. And they would ask us to assess certain components. They would ask us to assess what's called reaction time. And then, you know how I mentioned about vision, the visual perceptual skills, and somebody's strength. And using these assessment components, which are reimbursed by insurance, the doctor then made a determination of whether that person was safe to continue to drive or not. So I don't know if it was a go around in that area, but that is something that can happen because we can assess those different components. we just cannot take people on the road to do the on-the-road assessment.
Okay. One other question in there, I'm gonna get off, Matt Doiron, I'm gonna let him go in here and do his drop off for CEP Live. If you can drop the link. Matt?
Hey everyone, so in a minute from now, we're going to be having CP Community Live, and we're going to be joined by Maureen Burke. She's one of our occupational therapists, and I hope to see everyone there. I'll be posting a chat, a link in chat if you've never registered before. Hope to see
What is
everyone
she
there.
going to be talking about today?
I am not sure. Maureen usually goes kind of room by room in people's homes and kind of gives like different recommendations on like how like homes can be modified. And we usually talk a lot about the kitchen. And sometimes we talk about, you know, in the living room, outdoor space, that sort of thing.
Okay, good follow-up to this discussion. Thank you, Matt. He's going to put that link in there so you can work more with an occupational therapist through our talk today. And at this time, I think we'll look forward to having you at BrainTalk Live again next week. Crystal and Deja, would you please drop in the link for next week? Somebody wants to save them. Thank you so much, Ms. Jaya, for coming on and helping us with our understanding of occupational therapy.